the top of the hour. And so let's get started. Thank you very much for joining the Neurology lecture series where we have a stroke talk today on racial and ethnic variations in stroke risk factor and mechanisms. It's my honor and pleasure to introduce Dr. Sandeep Khot, who's giving the talk. A little bit about Dr. Khot. He did his elementary school at Bateman Elementary School in Galesburg, Illinois, where he was in the now legendary class of in first grade of Miss Young who he did he after a rough start he eventually graduated Bateman Elementary School, went to eventually to college at Vanderbilt University and medical school at Tulane University School of Medicine, and then University of Washington for neurology residency and fellowship, and now is one of the stroke faculty. And with that, I turn it over to Dr. Khot. He's going to share his screen. All right. And actually, shoot, sorry, only my video first. Okay. And then share my screen. All right. So I'm going to be talking, thank you very much for that introduction. We'll be talking about racial and ethnic variations in stroke risk factors and mechanisms today. This is a talk that I hope to review some of the race and ethnicity data on ischemic stroke subtypes, understand some of the common modifiable risk factors associated with stroke and racial and ethnic minorities. And then there's not much on treatments, but I hope that folks can become familiar with racial differences and intracranial atherosclerotic disease for preventive risk factor management strategies. But as mentioned, I'm not going to talk about a lot of things because this is a pretty broad topic, and it's important to note that there are a lot of avenues that you can go down when you're talking about these things, including stuff like social determinants of cerebrovascular disease, patient, provider, system, policy level determinants of some of the disparities in stroke care, as opposed to risk factors and mechanisms, and then genetic factors as non-modifiable risk factors for stroke. I also will not talk about much about interventions to address some of the risk factors and increase access to care, awareness of stroke symptoms. So each of these is its own topic, and I'm aware that that this can be a very broad topic. So try to focus on risk factors and mechanisms of disease. I'm going to start with a case, but this case is actually not a case of a patient. It's a case of a researcher. And this researcher was quite interested in sleep apnea and was applied for funding for a large study. And when this researcher received feedback, as many of you have ever put a grant together, know that there's a inclusion of minorities plan. And unfortunately, this researcher's place they were going to do research had a fairly diverse population, 30% non-whites, but the institute that they were applying to really felt that this was really unacceptable. And that term unacceptable is always harsh to get, but this researcher looked to see, after a period of bewilderment and frustration, did a deep dive into areas that I think he was unaware of, and found a lot of things that probably were in the literature, but just not completely evident. So, for example, the Hispanic American population, which is the largest minority group, has a greater incidence recurrence of strokes, worse stroke outcome, and a higher risk of post-stroke sleep apnea compared to non-Hispanic whites.
Excuse me, Dr. Khot.
Yeah.
Are you you're not sharing your screen? I just wanted to know if if you were showing something to the.
Sorry, I was, but yeah, sorry. Thank you very much for doing that.
Thank you.
It's not sharing the screen.
No, we just see you, but not the screen.
Oh, shoot, sorry. Okay, now, are you seeing a screen?
Yes. It
Okay.
Just in the yeah, okay, there it goes.
Got it. Okay, sorry. So this backing up things I'm not going to discuss in this talk. Sorry about that. Some of the social determinants of health, many of the other broader factors like genetic factors, and then some of the interventions that or each of these kind of its own topic. A case of a researcher who, started applied for a study, didn't, unfortunately, was found to be unacceptable with the group that he was hoping to study. Explored a little bit more in depth and found that a lot of things that he didn't know, and despite having a lot of interest in sleep apnea, just that certain groups with higher risk of post-stroke sleep apnea, and then also really didn't know that, as a population, Hispanic patients not only have a higher prevalence of sleep apnea, but also a stronger association with sleep apnea causing post-stroke cognitive outcomes, and highlight the need to address this in the sleep apnea treatment among Hispanics. I promise that I'm not going to talk about sleep apnea, so I am going to focus on disparities in mechanisms and risk factors, but not much about sleep apnea. So what do we know, in terms of non-modifiable risk factors for stroke? We think of age, that every successive decade after the age of 55 increases the risk of stroke. We think of that men are more likely to have stroke, although the absolute number of women is higher because women outlive men. Race and ethnicity, that two to fourfold higher among African Americans and at an earlier age, which I'll talk about. Hispanics also twofold higher, and also at an earlier age. Higher strokes among Chinese, which, depending on where they live, ischemic or hemorrhagic stroke, which I'll talk a little bit about. Geography, and this idea that there's a stroke belt and a stroke buckle, that a few states, I think it's 12 states in the Southeast are part of the stroke belt, but specifically a number of counties in Georgia and North and South Carolina have the highest stroke mortality in the country, called the stroke buckle. And the regard study, which I'll talk about, really focus on that area. And then heredity, that twofold higher among first degree relatives of strokes, and some linked to a chromosome has been linked to ischemic stroke risk. I'm going to be focused most on race and ethnicity, and this is a slide that was borrowed from Dr. Kira Becker way back when when she was my attending, and she had shared the slide of mechanisms of stroke. And if we think of stroke as ischemic and hemorrhagic, we think of embolism as about a fifth of stroke, and large vessel, this is a picture of an extracranial large vessel near occlusion of the carotid artery of about 20%, lacunar about 25%, cryptogenic, about almost a third of strokes, and then a third of ischemic strokes, and then hemorrhagic, mostly intratubular hemorrhage, but also subarachnoid hemorrhage. The first thing I'm going to talk about is, does this vary by race and ethnicity, what we call the TOAST criteria, the mechanisms of stroke. And there is some good literature to suggest it probably does vary by stroke subtypes vary, but a lot of this literature is pretty limited, and one of the bigger studies is the Northern Manhattan study, or NOMAS. And so NOMAS looked at is a population-based surveillance study in Northern Manhattan, had about a 14-year follow-up. A quarter of the population was Black individuals, 20% white, 50% Hispanic, so large Hispanic population. And in NOMAS, Blacks had about a 2.4-fold increased risk of stroke, all types of strokes. Hispanics, a 2-fold increased incidence of stroke compared with whites. living in the same urban community. And it was, the thought was in NOMAS was that this was mostly related to socioeconomic status and education. But what NOMAS did show was that this very complex three-way interaction between race, ethnicity, sex, and age, and that in determining your stroke risk, where the increased stroke incidence among Blacks really varied by age, with the strongest disparity observed in middle age. In middle age, the highest was observed was in Black individuals, followed by Hispanics and lowest in whites. And as the population aged, or the older population, that disparity became less, and then now the higher incidence was in white individuals. This really persisted till about the age of 75. By 85, the greatest incidence was observed was in Hispanics. And this was different in NOMAS compared to Mexican Americans, which has been studied in the basic cohort, where Mexican Americans, like Blacks, typically this disparity is strongest in middle age and declines with age. But in NOMAS, it was Hispanics, that disparity persisted all the way into older age. Another finding from NOMAS is that the type of stroke, again, was different. That cardioembolic was the highest among all subtypes. And this is thought to be related to, this is more of a recent trend with discovery of occult paroxysmal atrial fibrillation, but cryptogenic exceeded lacunar in whites, but not Blacks and Hispanics. And in Blacks, intracranial atherosclerotic disease and small vessel disease, lacunar, were to be summed up to be nearly as common as cardioembolic. So much higher rates of lacunar disease and intracranial athero in Black population, somewhat in Hispanic, and lower, especially intracranial athero and lacunar in the white population. This is another slide from NOMAS, again showing that Blacks and Hispanics compared to whites, there's about a 10% higher rate of hypertension. So overall, the study population, 74% had hypertension, but very disparate between Black 79%, slightly lower in Hispanics, and a good almost 15% difference between Blacks and whites. There was also other factors beyond diabetes, hypertension, and again, multiple studies have shown diabetes higher, especially in Hispanic populations, but physical activity, moderate to physical activity, higher in the white population compared to Black and Hispanic. And then in a multivariable model, the increased risk of stroke was attenuated after looking at socioeconomic factor, and further attenuated and really loss of any statistical significance after controlling for behavioral risk factors like physical activity, smoking, alcohol consumption, and then the important traditional vascular risk factors like body mass index, diabetes, and hypertension. There's not, even though they did look at some behavioral factors, a lot of them are not assessed in OMS, like, diet, lifestyle behaviors like sleep or stress, and other non-behavioral things like inflammation. So, thought-provoking, and but potentially still missing a lot of the things that could be driving some of the differences. The REGARD study is stands for the Reasons for Geographic and Racial Differences in Stroke or REGARDS. It was a study between 2003 and 2007. 50% of the population came from the stroke belt. I said 12, but I meant 8 southern states, and including the stroke buckle. Again, the stroke buckle is this coastal plains of North Carolina, South Carolina, and Georgia, where we have very high stroke mortality. And it regards had 1,800 counties. 60% of U.S. counties were recruited from in regards. 41% of the population was Black, so greater than 10,000 Black individuals, and about 1,000 strokes. About 43% of those were in Black individuals. This is looking at the Black to white hazard ratio with 95% confidence intervals for incident stroke after adjusting for sex. And again, this is looking at that same trend of decreasing hazard ratio between Black and white by age. So at between 45 and 54, 2.3 fold increased hazard ratio compared to 1.9, 55 to 64, and 1.5, 65 to 74, finally 1.2 at 75 to 65 to 74, and then really at greater than 85, 0.95. So, and this is actually looking at mortality, very similar curve where most of the disparity is at a younger age. Overall, in regards, the Black to white rates for diabetes were much higher for Black individuals, 29% versus 15% in these 8 southern states. And also mean systolic blood pressure was higher, 130 millimeters of mercury versus 125. 5 millimeters of mercury doesn't seem like too much, but that's quite a bit in terms of a large population study like this. And then interestingly, the treatment with antihypertensives was actually higher in Black, 62% versus 42%, suggesting that even with these higher rates of treatment, Blacks individuals had greater effects of the blood pressure on their risk of stroke. There's something I'll show in a little bit. This was followed in another study in 2004, similar, looking at the different TOAST criteria. The Greater Cincinnati, Northern Kentucky stroke study, where small vessel strokes again and strokes of undetermined cause were higher among Black individuals compared to whites. And so again, small vessel, 40% compared to 21%, and undetermined or cryptogenic, this is not percentage. This is the age-adjusted incidence. So 40 out of 100,000 versus 21, and then 125 versus 65. But a risk ratio of 90% increase in small vessel and undetermined. Other ones were also increased, to a lesser extent. Large vessel by 40% and the cardioembolic, but clearly small vessel and undetermined were higher, much higher in Black individuals. I've cited another study here and this is from the atherosclerotic risk in communities, or ERIC study, and they also found a 3-fold increase in lacunar strokes among Black individuals compared to Caucasians, but no difference in cardioembolic in that study. This was a study in Washington, D.C. Again, same, looking at a much smaller study, 350 strokes. This was a 350 overall, 260 Black individuals compared to 89 white individuals. But again, showing that this study used brain MRI versus CT that had been used in some, and there was a statistically significant difference in men having higher rates more men having high rates in the white population, and then higher rates of hypertension in the Black population, and diabetes. Also higher, not as statistically significant, but higher rates of diabetes as well in the Black cohort. There was no significant difference by race for the proportion of strokes that were cardioembolic, large artery, small vessel, or undetermined in this study. I just want to point out at least some studies have not shown this difference in stroke mechanism. So this was an earlier study in Washington, D.C. that looked at 25% white versus 75% black by stroke subtypes using brain MRI again. And they were very statistically significant. They looked at statistically significant differences in the mechanisms of stroke and really found no significant difference. And so that, cardioembolic 30 versus 31, lacunar 10 versus 8%, small vessel 10 versus 11, and then undetermined 35 versus 44. The other determined was the only one that was different, and it was higher in whites than blacks, but didn't show the same finding of higher lacunar strokes, higher large vessel athero in blacks, and lower cardioembolism in black individuals. So one way of looking at this types of mechanisms is looking at carotid revascularization, so CEAs. There are much less carotid revascularization in the African American and Hispanic population, despite having higher cardiovascular risk factors. And the question in this study was, is this due to disparities in access to care, or is it truly due to a low incidence of severe carotid stenosis? In fact, about greater than 90% of CEAs are done in the United States, are done in white, in the white population. And so the American Heart Association does not recommend carotid screening in the general population, but there's an organization called Lifeline Screening, and they will do screening. It's a direct-to-consumer company in which individuals can self-pay for vascular assessments. And they looked at patients who had carotid stenosis. These are, again, people who offer to get it done. So not through their insurance, they self-pay for it. It's between 2005 and 2019. The cohort's pretty large, 6 million participants. So they're all less than 85, and they're stratified on the basis of race and ethnicity, sex, and age. And so they looked at high-grade significant stenosis by Doppler, which they define here. And they looked at this by different races and stratified by sex. And there was a significant difference between the populations. So if it's harder to see on these graphs than it is in the table that they provide, but this is on the left here is what the census population 2015 is in the United States. So 72% white, 11% black, 11% Hispanic, 5% Asian, and 50% women, 1% Native American. So what was the population with high degree stenosis? 82% of the studies they did, 82% of the cases with high grade stenosis were in the white population. Only 7% of the black population had severe stenosis, only 7% of the Hispanic population, only 3% of the Asian population, 1% of the Native American. So much higher rates than the general in the general population among whites, much lower rates than you'd imagine, despite those multiple risk factors in blacks and Hispanics. They did do a sensitivity analysis in this study where they looked at the impact of risk factor adjustments on this prevalence of high-grade stenosis in about almost 3 million participants. And they really found that adjustment of the risk factors, so hypertension, diabetes, really had no impact on the estimated racial differences. There's some important conclusion to this. I mean, I think, clearly this study has issues because it's, this is a self-pay, it's not a, but they point out in the study that their population was actually pretty similar to the regards in terms of the ratios of black-white prevalence of risk factors. And so very similar general population, but again, limited because this is these patients are being self-referred and they have differences in financial resources. They also the places they're testing, this was mostly in Florida, low proportion in general of Black and Hispanic individuals. But overall, they conclude that there's a substantially higher prevalence of hypertension and diabetes in the Black individuals than white individuals. A very similar prevalence of dyslipidemia in Black and white individuals. But despite that, who gets carotid stenosis? Almost, in this study, very much the white population, much lower in ethnic minorities, racial and ethnic minorities. I don't want to just focus on Black and Hispanic populations. There's other groups, and this is a study that looked at Southeast Asian and specifically Asian Indian population. So this was the Middlesex County Ischemic Stroke Study in New Jersey, which has one of the largest Asian Indian populations in the United States. They found much higher rates of diabetes in Asian Indians, 55% compared to only 48% in Hispanics and 43% in African Americans and only 35% in Caucasians. Lower atrial fibrillation in the Asian Indian population, only 7%, and compared to, especially compared to Caucasians, which is 27%. And then much higher rates of small vessel occlusion, 25% lacunar strokes, much higher rates, 25% compared to 12, 17 in Hispanics, closer, 21%. They, in this population, Asian Indians had much, and African American and Hispanics all had higher rates of diabetes and lower rates of atrial fibrillation. But the only significant differences really were between all the groups was lower cardioembolic and higher small vessel occlusion among Asian Indians. Some of the changes that we're seeing are not static, and they change over time. And this has probably been shown more than any other study in China. And this was a study done in Beijing, China, where they looked at this pattern of transition from hypertensive hemorrhagic stroke to ischemic strokes. And so there's been evidence that overall, many developing countries have much higher rates of hemorrhagic strokes relative to ischemic strokes. And then as a recognition of hypertension becomes greater in this country, and there's an increase in Western style diets, the proportion of hemorrhagic stroke declines and the proportion of ischemic strokes conversely goes up. And this is exactly what was shown in Beijing in a period between 1984 and 2004. This was a really complicated table, so I've just kind of gotten to the bottom, kind of cut out the bottom of the table, and it's showing overall strokes, ischemic strokes, and hemorrhagic strokes. And what it's showing is that over this period, 84 to 2004, there was a decline of 1.7% annually in the incidence of hemorrhagic stroke, but during the same period of time, there was a 8.7% annual increase in the risk of ischemic stroke, which gives you a total of the between the two of about 6.7% increase in overall strokes in Beijing during this period. The proportion of, and kind of what you'd expect, the same if you have improvement in hypertension, worsening diet, more westernized, closer to our population, that during the same period they saw a proportion of deaths from cerebrovascular disease decline because less hemorrhagic strokes, but the proportion of ischemic heart disease actually increased during the same period. So as ischemic strokes went up, so did ischemic heart disease. Which is interesting, just that this is a much more dynamic thing than we think of in terms of these mechanisms of stroke. it's just showing you that. I thought this was very interesting. Speaking of this possibility, this is dynamic, and this was this idea that is the stroke belt worn from childhood, and this was using the regards data, and this was community-based study of some regional differences in stroke risk. And what they found was that your childhood residency and your proportion of life in the stroke belt conferred a higher risk in middle and older age, even among people who no longer lived in the area. And so this was a 2007 paper where they looked at first stroke by state of residence in one of seven stroke belt states during childhood, even among people who no longer live there, using the health retirement study. This actually, the first study is actually health retirement study, the second one's regarded, sorry. So this one is the health retirement study. It's 18,000 US adults greater than 50 years of age. And after controlling for a lot of demographics, socioeconomic, and cardiovascular risk factors, all kind of listed down here, some of the things they controlled for. When they fully controlled for all these, they found that, if you had about a 21% increase in your in a fully controlled model, 21% increase in your risk of stroke if you lived in the stroke belt just during childhood. If you lived at enrollment alone, not a significant increase. But if you lived at both childhood and enrollment, also about a 15% increase. So this idea that, when is this most crucial period that you're influenced in, childhood obesity and other factors that could be driving your risk of stroke may start quite young, even during childhood. And this was followed by the regard study. And similarly, multiple models here, a demographic model, a socioeconomic model, a Framingham model. Framingham uses all these, if you don't know, the Framingham stroke risk score uses, blood pressure medications, blood pressure, history of heart disease, diabetes, left ventricular hypertrophy, atrial fibrillation, current smoking. But when was the period that, and again, regards at 25,000 patients greater than 45 years of age, and they looked at exposures at different periods, age 0 to 12, 13 to 18, 19 to 30, 31 to 45. In a fully controlled model, none of these were significant except to the age 13 to 18 that that your risk of having a stroke, if you lived in the stroke belt during the age 13 to 18, you had the highest risk, or you had a persistent risk after you're controlling for all these things, demographic, socioeconomic status, and vascular risk factors. The other time periods were significant in other models, but once you control for risk factors, really lost significance. Again, suggesting that childhood is probably the most important period of vulnerability to stroke belt residence and as a predictor of future stroke. Pretty fascinating. I do want to talk a little bit about the Framingham stroke risk profile, because it's one that we have used as the main cause of main risk factors for stroke. And it's the Framingham stroke risk profile. It's continually updated. It was designed to estimate your 10-year risk of stroke stratified by sex, but it has limited utility because number one, it focuses only on stroke. That's an issue. And then secondly, it's actually was not a very diverse population. And so we used it a lot. And we always focus on these risk factors, but probably one that's better has been the ASCVD risk estimator. And if you don't use this, it's a very useful one. So in 2013, the American College of Cardiology and American Heart Association developed and validated in a very large population guidelines for the evaluation and treatment of cholesterol in order to reduce your 10-year risk of ASCVD, atherosclerotic cardiovascular disease. And that's defined as non-fatal MI, coronary heart disease causing death, fatal or non-fatal stroke over a 10-year period. The good thing about this calculator is that it was used, the study that created it was included stroke and cardiovascular disease, so maybe more useful. And it was actually one of the first to include a large amount of data from African Americans, allowing it to incorporate race as a predictive variable and making it particularly useful in Black communities. I feel that this is just a screenshot where I put in a 50-year-old man who was another race. And it's a very honest calculator. It tells that, that these estimates underestimate this for other race ethnicity, especially American Indians, some Asian Americans, some Hispanics, and overestimate it in some, including some Asians of East Asian ancestry, some Hispanic, especially Mexican Americans. I mean, this is like, about as refined as you can get compared to the Framingham. And if you haven't used it, the link is down here, but it is a much better calculator for especially African-American population, but even other populations to define both heart disease and stroke risk. It has a therapy impact and advice tabs. And then it does focus, I will say, a lot more on statins, that provides the intensity of statin treatment and on predictive risk level. So it does have some shortcomings, but but I'd say it's a good calculator overall. A study that was done that is probably much more focused on populations outside of the United States was a case control study called InnerStroke. And InnerStroke looked at 22 high, middle, low income studies, and they found 10 modifiable risk factors that explained 88% of risk of ischemic stroke. And this study enrolled about 3,000 patients, and actually they had 2,300 ischemic stroke and 663 hemorrhagic stroke. And the first 5 factors that are listed here, hypertension, smoking, waist to hip ratio, diet score, and physical activity were thought to account for 80% of the global risk of stroke. So I've circled the ones that I'm going to focus on when I talk about risk factors. But these 5 are thought to, and the odds ratios are listed here for all of them in terms of risk for stroke. A much better study in terms of a very diverse population. They also, a couple of things to point, this waist to hip ratio, they really focus on abdominal adiposity as measured by the waist to hip and as a major contributor to stroke risk rather than increased weight, which is measured by BMI. BMI was not associated with stroke risk in this population. And this is being more and more recognized, and I'll talk a little bit more about it. Risk factors for intraperitoneal hemorrhage are not shown here, but it's really hypertension, smoking, waist to hip ratio, diet, and heavy alcohol consumption. This was majority of strokes were first strokes, and so this was really focused on primary prevention. This is getting back to regards, and again looking at considering that the majority of strokes, the higher risk of strokes is in an African American population. This study looked at mediation analysis. Before I talk about risk factors in general, it's important to talk about what percentage of ischemic stroke risk is probably related to risk factors. And so this study looked at patients in regards looking at greater than 55 years of age, and especially showed this higher risk in younger age for Black people compared to white individuals. But after they adjusted for demographic and traditional risk factors based on Framingham, the excess stroke risk reduced by 41% from 2.2 to 1.7. In other words, about less than half of Black excess risk, stroke risk, was attributable to a higher prevalence of risk factors. The idea being that mediation analysis, there are many other things, and it's probably beyond the scope of this talk, but it's worth considering that race itself is probably not causally associated with a high prevalence of risk factors, but associated with it due to some common upstream fundamental cause of disparities, like lifestyle choices, diet, exercise, early life experiences, residential segregation, racism, all these things that are probably not, even though this talk is focused mostly on these risk factors, it's just important to note that in terms of a mediation analysis, probably about 41% of it is related to risk factors, and other things that are not measured are probably also contributing considerably. I will point out that when they looked at what led to this greatest, the one that had the biggest effect was systolic blood pressure. The mediation attributable to the factor 45% related to systolic blood pressure. And which I'll talk about now, which is the population attributable risk of in inner stroke, that big study for self-reported high blood pressure greater than 160/90 was 45.2%. So meaning if you eliminated hypertension from this population, you could reduce the risk of ischemic stroke by about 45%. Intracranial hemorrhage by 73.6%. And multiple other studies have shown this. PATS, the relative risk reduction in blood pressure treatment was about 30%. In Progress, these are old studies, was 43%. In Progress, the effectiveness of the antihypertensive treatments diminished as baseline blood pressure declined, but even people who were normotensive benefited from blood pressure reduction in Progress. And then one of the top contributors to racial and ethnic disparities in health is hypertension is considered one of the top contributors. Black individuals have an earlier age of onset, longer duration, greater severity compared to white individuals, and Black and Hispanic individuals are more likely to have worse blood pressure control even when they are treated, and more detrimental brain effects, so stroke, cognitive dysfunction, greater white matter hyperintensity. A lot of citations here, but hypertension, if there's one driver of stroke, coronary disease is a little bit different, but stroke very much related to hypertension. Not only do Black Americans have higher rates and more severe hypertension, but they also have a greater impact of hypertension on their risk of stroke. So again, getting back to the Regards study with over 2003 to 2007, 4.5-year follow-up, looking at the racial difference in the impact of systolic blood pressure using a proportional hazard models, the overall, the impact of high blood pressure and stroke was threefold greater for Black than white individuals. This is people who were, if for every 10 millimeters difference in your systolic blood pressure, there was an associated 8% increase in stroke in whites, but a 24% increase in your stroke risk in Blacks. It was less after adjustment for demographic factors. Shown here on the right side, but still significant. So a significant difference in every 10 millimeters mercury, a greater effect in one ethnic population over another ethnic population. And then this was probably the greatest between the ages of 45 to 64, where the hazard ratio was 2.38 for those with stage 1 hypertension. So much higher among people in that younger age group. I'm sorry, I'm pointing that out here. So this was another study showing that the effects of hypertension are really important contributors to the burden of ischemic stroke in, again, younger individuals. So this was a stroke prevention in young adult study. And this was a cohort case control study looking at first ever ischemic stroke between the ages of 15 and 49. So these are young people from 59 hospitals in the Baltimore, DC area between 92 and 2007. They had 1,000 cases, 1,000 controlled, about 1,000 cases, 1,000 controls. About half were Black, and the mean age was about 40 years. So again, pretty young people. And it's showing the population attributable risk for 3 major risk factors for stroke: smoking, diabetes, and hypertension among, again, white men, Black men, white women, Black women. Overall, smoking was the strongest contributor for ischemic stroke in white patients. You can see a bigger difference in white men and white women compared to Black men and Black women. but hypertension was much greater as a contributor for risk of stroke, 45.8% in Black men and 26.4% in Black women. Diabetes was a strong contributor to ischemic stroke in both Black men and women compared to white men, compared to white patients as well. And again, showing that different effects for different risk factors. Same group, sorry, I'm pointing out the really significant ones. Again, current smoking, especially white women who have an increased risk, increased rates of smoking, and then especially Black men for hypertension. Same group out of Baltimore and DC looked at the stroke prevention in young adult study. Again, mean age about 40 years, looking at having concurrent vascular risk factors. And so the 4 risk factors they looked at were obesity, hypertension, diabetes, and smoking. And your risk of having in Black patients and white patients, 1 risk factor, 2 risk factors, 3 risk factors, or 4 in the cases versus controls. And what they found, again, is that the odds of having a stroke increased exponentially as you had each one of these risk factors. And Black individuals were about 6 times more likely to have all 4 risk factors compared to the white patients. So, you know, higher risks, but and especially hypertension, but you know, even the other ones, smoking, obesity as well, higher. Having all 4 of those higher in the Black population. And these are just the odds ratio of the entire population, both white and Black, 2.1, 2.6, and significant in terms of this exponential risk with each risk factor. The ethnic and racial disparities related to treatment and untreated hypertension and intracerebral hemorrhage, the ERIC study. So same looking at stroke, but now looking only at intracerebral hemorrhage. And intracerebral hemorrhage is a disease that accounts for only about 10% of strokes, but it accounts for 50% of mortality. And if you work in harbor, you know this, that you know very high rates of dying from intracerebral hemorrhage. So this study looked at 42 recruitment sites, about 958 white patients, 880 Black patients, and about 776 Hispanics. So in case control pairs between 2010 and 2015. And they looked at both treated and untreated hypertension. And again, the risk of intracerebral hemorrhage was amongst Black and Hispanics compared with whites as well. Both the treated and untreated hypertension conferred a greater risk of intracerebral hemorrhage, and Blacks and whites. This is overall compared to Blacks and Hispanics compared to whites, and P for interaction was less than 0.001. So similar higher rates as you'd imagine with high blood pressure. I'm going to run out of time because I think I'm spending too much time on these slides, but I'll try to go through quickly. Just a couple of others points is that even with control of blood pressure, the regard studies show that in people with history of stroke and a non-history stroke, risk of stroke, if you had a history of stroke, your sorry, hold on a second. So this study is looking at most of the studies focus on primary prevention. This is a study looking at secondary prevention, and so examine racial differences in blood pressure control following a stroke using the American Heart Association guidelines. And so these were patients who were taking hypertensives on the left, and those who had no history. Sorry, I'm going to confuse myself here. I'm going to actually move on from this because I'm trying to remember what people who did and do not have a history of adjudicated stroke, and then who between 2003 and 2007, and then the second visit in 2013, 2016. Overall, Black patients were younger, they were more likely to be women, and that the proportion of controlled blood pressure was whether you had a stroke or did not have a stroke. When you had a stroke was much lower in Black patients compared to white patients. And this was significant even after controlling for demographics, socioeconomic status, and risk factors. I want to talk about one other study of hypertension, and I think I'm gonna have to move on, but this is a very interesting study to me, looking at two populations. One was the population, the large population in mostly in the southern United States, but also the Siren study, which is a case control study, the largest study in Africa. And the thought of this is that 87% of stroke burden is in low and middle income countries, and death from stroke is much higher in these countries. So this study looked at 2,000 stroke patients greater than 55 years of age, some from Africa, indigenous Africans, compared to African Americans and compared to European Americans, using both Siren and the Regard study. Indigenous Africans and African Americans were significantly younger than European Americans, 68 versus 73 versus 76. Indigenous African Americans had a higher prevalence of hypertension and diabetes, comparable frequencies of dyslipidemia, and a lower prevalence of cardiac disorders compared to European Americans. And as you'd expect, hemorrhagic strokes were twice as frequent, given that hypertension was significantly higher in indigenous African population. There was also a significant variation in their subtypes. So cardioembolic, much lower in indigenous African Americans compared to African Americans, and especially compared to European Americans. And again, lacunar, much more higher risk in indigenous Africans compared to African Americans and European Americans. I'm going to skip this because just for the sake of time. I will say that, this idea that what is an unhealthy environment, how does it get under the skin, has been something that how stress may influence risk factors like hypertension. For the sake of time, I'm also going to kind of go through this quickly, just metabolic syndrome. What is metabolic syndrome? So it's at least three components: high fasting glucose, high blood pressure, low HDL, high triglycerides, and abdominal obesity. About a third of the US population has metabolic syndrome, compared to only about 13% with diabetes. And the population attributable risk is about 19%, for metabolic syndrome, compared to about 7% for diabetes. So, there's something specific about this that's driving risk for stroke. Overall, studies shown about a double risk of ischemic stroke, and the two of all the risk factors that are strongest predictors are fasting glucose and hypertension. The odds ratio for risk of stroke was 1.49 for a stroke or TIA. In a study, this was an Israeli study of about 14,000 patients. And then compared to 2.29, you've had frank diabetes. So really, whether it's high fasting glucose or frank diabetes, really change your risk of stroke, and especially more pronounced risk of stroke in women compared to men. Rates really vary, and this is from the NHANES study. Among populations overall, much higher in Hispanic, which about a third of Hispanics have metabolic syndrome. I thought this was a very interesting study, which I'm not going to be able to explain completely, but it's called a Hunt study, and it looked at people who were overweight but were healthy, other metabolic healthy, meaning they didn't have these other risk factors, but versus metabolic unhealthy. And they defined this as, being metabolic unhealthy was waist circumference, and then, non-fasting triglycerides, decreased HDL, high blood pressure, a lot of the metabolic syndrome things. And what they found was that the risk, even if you were overweight, was not higher for stroke than it was if you were metabolically unhealthy and overweight. Then you have very significant risk of 30% higher, which was interesting that we think of obesity, but BMI is not a good characteristic. It's really that waist to hip ratio. And these were the percentages of people in the study that had, in this Israeli study, that were overweight, but like I said, really driven by the metabolic syndrome. I'm going to run out of time, but I want to just finish up. There's a lot of stuff on it, which I didn't realize I was going to have a little time, but I'm going to end on talking about intracranial atherosclerotic disease. Just overall that ICAD, this is the data from the NOMAS study from 93 to 97, and really showing that comparing these population intracranial atherosclerotic disease, your rates of having ischemic stroke, if that particular subtype, much higher in Hispanics than whites, much higher in blacks than whites, compared to extracranial. And then ICAD is thought to be 10% of ischemic strokes, but 30 to 50% in Asia, a lot of racial ethnic variations, 6 to 10% in whites, but higher in blacks, but especially higher in Asians. The recurrent rate of stroke risk used to be very high, 15%, compared to 3 to 7% for non-cardiovascular strokes, considerably. And this study, slide showing that comparing WASD, where the endpoints were 21 and 22% in the two groups, with over 1.8 years of having a stroke. You can see Sampras much lower, and then some of the more recent studies even considerably lower, as we've been more aggressive about treating LDL and treating diabetes in these studies. Very poor control in WASD, very good control in the more recent studies. So some of the non-modifiable and modifiable risk factors for intracranial atherosclerotic disease, really the metabolic syndrome, probably one of the big ones. And I'm going to skip this, is just showing the number of plaques using vessel wall imaging, much higher in a black population compared to white. And then that this racial difference changes over time, that even in the black men, even at the age of 70, more than 50% had evidence of ICAD, whereas in the white population, it really took, to get to 50%, really was a much older age before they got to 50% intracranial atherosclerotic disease. And so stroke recurrence, things to focus on, metabolic syndrome definitely, and then these and blood pressure, and then especially in the black population. I went through that super fast. I just wanted 2 plugs and a nod. I just want to point out that I had a recent opportunity to look at our feedback for our talks. I run the lecture series, and these are some of the talks just that I've done since 2015. And I looked at not only the talks, but how little feedback we get. And so, please, this is a link to give feedback. At the bottom is another, our second plug is, if you enjoy our talks, to please consider donating for our talks. There was a whirlwind talk, but I do want to thank 2 people who on the bottom these are both mentors of mine. So Dr. Devin Brown at the University of Michigan, who's been very helpful. And as everyone knows, Dr. Longship doesn't allow you to take his picture, but if you're very lucky, you can find old pictures of him like this one. And with that, I'll take questions. And sorry for going over time. I'm usually the one that asks questions, and so now that I'm not here to ask questions, I'm hoping someone else will pipe up. Too fast, too much information.
I think it might help if you take down the picture.
All right. People are stunned by the picture.
Oh, wait, sorry. Could you go back to the QR code so I can actually give you feedback?
Oh, yes, sorry. 1 second. Let me try. You can see, there you go, sorry. And there's also a link in the chat box to an evaluation link, so you can use that. All right, well, it's a lot of information. It was fun to do the talk, but I think I apologize for going over time. So I think I'm right at the top of the hour. So if there's no other question, we'll wrap it up here. All right, thanks everyone, and I'll leave that up for a second for people to scan if they want. And
you aren't sharing your screen.
Sorry. Can you see it?
No, not yet.
How about now?
There you go.
Okay. There's a quick question here. Do you think allostatic load or stress is really like contributing to stroke more than metabolic? You know, I think at least based on that regard study, it wasn't. It's you know this issue of it's hard to imagine a 13 to 18-year-old has a significant metabolic syndrome, but it's possible. But it seemed like that was a regard study, and that other study was suggesting the childhood than we think. And so is it because of habits created during childhood, or is it because of other things? Hard to say, but I think overall, yes, I do think there's a good literature about stressors early in life contributing to stroke risk. I did not have time to cover for sure, but yeah, I think that's a very good question. All right, well, I think I will stop sharing now, and thank you guys very much, and we'll wrap it up and do it again soon. Thank you.